Hi everyone, and welcome to our weekly podcast brought to you by VJOncology. Today, we will be covering gastrointestinal cancer updates from ESMO 2025, which we attended live in Berlin. This podcast can be found on the GI Cancer channel on VJOncology, an independent medical education platform which is supported by Takeda, Gold, and Gilead Sciences, Silver. Supporters have no influence over the production of content. The levels of sponsorship listed are reflective of the amount of funding given. To begin, with Kohei Shitara from the National Cancer Center Hospital East in Japan, who comments on the FORTITUDE-101 trial of bemarituzumab plus chemotherapy in patients with FGFR2b positive gastric or gastroesophageal junction cancer.
In this ESMO, we have some exciting or important presentation. First is bemarituzumab plus chemotherapy, FORTITUDE-101, especially for FGFR2b positive population. FGFR2b positive was defined by 10% threshold, and there is some overlap with FGFR2 amplification. So this is a clearly fast study to test this molecule in phase 3 for gastric cancer. And that study met the primary endpoint, overall survival at the interim analysis. As already presented, it showed median survival more than 5 months difference with a hazard ratio around 0.61. However, additional 7 months follow-up somehow changed the result with attenuation of difference of overall survival with median less than 2 months difference and a hazard ratio 0.82. Yeah, so it is very hard to conclude this study, but maybe we need to consider this final or follow-up overall survival as most important result. So in that case, to receive regulatory approval might be not easy, but it suggests at least some range of activity in this unmet need population. And currently, very importantly, another FGFR2b phase 3 trial is ongoing as a FORTITUDE-102, which combines chemotherapy, checkpoint inhibitor, and nivolumab. And safety profile is in line with the previous report. Bemarituzumab-induced eye toxicity or keratitis, but it is in line with the previous report. So anyway, it is not easy to interpret and not easy to conclude, but let's stay tuned for 102 study, which will be reported in the near future.
He also goes through findings from a phase 1/2b trial of ASP2138, a bispecific T-cell engager targeting Claudin 18.2 and CD3 in patients with advanced Claudin 18.2 positive GI cancers.
ASP2138 is a bispecific T-cell engager agent which binds Claudin 18.2 and CD3 on lymphocyte. And it activates lymphocyte around Claudin-positive tumor cells, and because of the release of cytokine, it results in cancer cell killing. So this agent targets Claudin 18.2 because it is already established to target in gastric cancer because of previous phase 3 trial of zolbetuximab, which improved overall survival with chemo plus zolbetuximab. Zolbetuximab is an IgG monoclonal antibody which activates NK cell macrophages to induce ADCC, CDC, and ADCP, and different from ASP2138, which activates lymphocyte. So that is an important rationale to develop this agent for Claudin 18.2 positive tumors. And in this phase 1 trial, we evaluate single agent safety as well as activity. We especially test both subcutaneous infusion and IV infusion. So first poster which I presented in this ESMO is regarding IV infusion, which enroll both gastric and PDAC population. First, safety profile is within acceptable range. Around 30% of patients experience cytokine release syndrome, or CRS, but most of them were with grade 1 and grade 2 and well controlled by established management protocol. Another common event or GA toxicity like nausea and vomiting, it is not easy to conclude, but a little bit lower than that of zolbetuximab in terms of incidence. The overall efficacy is not high in terms of response rate, but 10% patient achieve response, and this was observed regardless of Claudin expression, and around 30% additional patient achieved disease control. And interestingly, there is a trend of a higher PK or dose and better disease control rate, which led to us to conclude one dose as a established recommended dose. And then we also test the subcutaneous infusion, which also showed a very similar safety and efficacy profile. Subcutaneous infusion is a little bit less frequency of cytokine release syndrome and better to combine with first-line chemotherapy and the second-line chemotherapy. So we combine it with a first-line FOLFOX plus pembrolizumab and paclitaxel plus ramucirumab. And both cohorts showed acceptable safety profile. Also, we observed the toxicity which reflects each component of chemotherapy and ASP2138 as well as the pembrolizumab in front line, but overall manageable. Interestingly, more patients associated with gastritis with second-line paclitaxel and ramucirumab. At this stage, we are not sure whether this is class effect, especially combination with paclitaxel or ramucirumab, or just based on relatively small sample size. So we need to carefully follow up with additional patients. And efficacy is very promising with more than 60% response rate with first line and more than 30% in second line, but we need additional follow-up to see additional efficacy results.
Next up, with Michele Reni from Italy, who discusses results from the CASSANDRA trial of short versus long course pre-operative chemotherapy in patients with resectable or borderline resectable pancreatic ductal adenocarcinoma.
So Cassandra was a phase 3 trial based on a double randomization. The first randomization was presented earlier this year at ASCO meeting. The second part, that is the object of today, was a short versus long preoperative chemotherapy. Patients who were progression-free and without limiting toxicity after 4 months of chemotherapy were randomized for the second time to receive 2 further months of preoperative chemotherapy versus surgery, immediate surgery, and completing the chemotherapy after surgery. So long versus short preoperative chemo. So what we did observe was that there was no difference in terms of event-free survival between the two arms. So there is no difference in the primary endpoint that was event-free survival. We observed a difference in terms of secondary endpoints because the longer chemotherapy was able to achieve a significantly higher pathological complete response rate and zero resection rate and CA99 response rate. Furthermore, there was a higher number of cycles that were delivered in patients with a long chemotherapy and also a better dose intensity.
Following on, Stephen Lam Chan from the Chinese University of Hong Kong discusses the Phase 3 IMbrave 152 or Skyscraper 14 trial, which evaluated the addition of tiragolumab to atezolizumab and bevacizumab as first-line therapy for a locally advanced or metastatic hepatocellular carcinoma.
So in 2025 ESMO meeting, there had been a presentation of the Phase 3 clinical trial IMbrave 152 and the Skyscraper 014. In this study, the patient with advanced XCC were randomized to 2 arms. The first arm being the atezolizumab and bevacizumab plus the tiragolumab, which is a TIGIT antibody. And the control arm is the atezolizumab and bevacizumab. All patients were treatment naive, i.e. it's a first-line setting. And the primary endpoint was both progression-free survival and also the overall survival. Unfortunately, the readout is that the study failed to reach its primary objective, i.e. there's no improvement in the progression-free survival. And also the overall survival also, although it's not mature yet, but the trend is that there will not be any significant differences in the overall survival. So overall, the study is negative, suggesting that adding tiragolumab will not improve the outcome of the patient who are already on the atezolizumab and bevacizumab. Regarding toxicity, we don't see any new toxicity signal, although generally the patient treated with tiragolumab, they experience more TR treatment-related adverse event, especially the skin rash or some patient with immune-mediated toxicity. So this study basically cannot reproduce the result that we observed with the Morpheus liver phase 2 study. And of course, we need to learn from this study. Maybe in retrospect, maybe the phase 2 study, the control arm has been too small number, And also the response, they have recruited those patients with poor prognostic features. And also, I think another key point is sometimes don't be too disappointed by the result. We have experience with XCC is that we need to go through some phases that we learn from the negative trials before we see some breakthrough in the treatment.
He also goes through the findings from the CARES-009 trial of perioperative camrelizumab plus rivoceranib versus surgery alone in patients with resectable hepatocellular carcinoma.
So CARES-009 study is a randomized study testing on the perioperative use of the immune-based treatment in patients with early stage and operable XCC. It's mainly run in China. It's a multi-center study. So in brief, the patients who are suitable for surgery according to the China guidelines, i.e. those, but at a high risk of recurrence, i.e. those are stage 1B to stage 3A, the China liver cancer staging system. They also recruit patients with VP1 and VP2, vascular invasion, but excluded those patients with VP3 and VP4. The patient, of course, need to be clean from the extrahepatic diseases. So they are randomized to one arm, which is camrelizumab and viroceranib for 2 cycles, and then proceed to surgery. And then afterwards, receive the adjuvant camrelizumab and viroceranib for 15 cycles, making the systemic therapy plan a total of 1 year. And the control arm is just surgery followed by the surveillance. So the key point, the primary endpoint is event-free survival. So the key result is that there have been significant improvement in the event-free survival with a hazard ratio around 0.6 something. And also, when they look at other, like pathological response rate, they also see, quite a sizable number of patients achieving, major pathological response or even, pathological CR. And the toxicity-wise, overall, we don't see any unexpected signal, although there's still some proportion of patients developing grade 3-4, toxicity around 20%, from the new, perioperative treatment. So this study actually confirms, the values of the perioperative treatment in patients with operable XCC. Of course, in my discussion, I did raise some point. For example, whether the population stage 1B to stage 3A, which is really the surgical candidate according to international world, perhaps we need a more refined populations like BCLC-A or some BCLC-B diseases. Another point is noted that only 19% patients could complete all 15 cycles of adjuvant therapy. This has raised a point whether we need such an intensive treatment after the surgery, especially when we know that the adjuvant immunotherapy trial for 1 whole year did not improve the outcome of the patient from other clinical trials. I would advocate perhaps we need some abbreviated course of adjuvant therapy, and also which is adapted according or adjusted according to the pathological response achieved. But anyhow, this is I would say, landmark study confirming the role of perioperative treatment. I expect this regimen will be approved by China regulatory soon. And of course, whether it can be accepted totally in the West, perhaps not at this moment, but definitely I will expect it will pave a number of the randomized study for other regimen in an operative setting in XCC.
Finally, we have Anwaar Saeed from the University of Pittsburgh, who provides an overview of the STELLAR-303 study, a phase 3 trial evaluating zanzalintinib plus atezolizumab versus regorafenib in patients with previously treated metastatic colorectal cancer.
Thank you for having me. I'm thrilled to present the results of the STELLAR-303 study, which I presented at the ESMO Congress, and we published the results simultaneously at the Lancet. The STELLAR-303 trial is the first immunotherapy-based phase 3 trial to show significant survival advantage in patients with chemorefractory, metastatic, or advanced stage colorectal cancer that are not MSI high or mismatch repair deficient, which represents 95% of the cases. Zanzalintinib is differentiated multi-tyrosine kinase inhibitor that targets multiple kinases, including the TAM kinases, as well as MET and VEGF receptor. In preclinical studies, zanzalintinib have shown synergy when combined with immune checkpoint inhibitors that have led to exploration of zanzalintinib in combination with immune checkpoint inhibitors in early phase clinical trial. I have developed an early phase trial exploring the combination of an earlier generation multi-tyrosine kinase inhibitor called cabozantinib, which has an overlapping tyrosine targets with zanzalintinib. And we combine it with immune checkpoint inhibitor in the Camilla trial. And in that study, we have shown promising signal in patients with chemorefractory metastatic colorectal cancer. So that, in addition to the findings from the phase 1 STELLAR-001 study that combines zanzalintinib with atezolizumab versus zanzalintinib alone, we have shown also promising signal favoring the combination as opposed to zanzalintinib alone in patients with chemorefractory colorectal cancer. So this evidence have provided the ground to launch the phase 3 STELLAR-303 study. In this phase 3 trial, the population that enrolled on STELLAR-303 were metastatic colorectal cancer patients who progressed on 2 prior lines of chemotherapy and have tumors that are not MSI high and not mismatch repair deficient. Patients were randomized 1-to-1 to either receive zanzalintinib plus atezolizumab or regorafenib dosed at the regulatory approved labeling. Stratification factors we used in the study were geographic region, presence or absence of RAS mutation, and mutations, and presence or absence of liver metastasis. The study has dual primary endpoint of overall survival in patients with in the intention to treat population, as well as overall survival in patients who do not have liver metastasis. The results I presented are on a planned overall survival in the intention to treat population. And I also presented interim analysis of overall survival in patients without liver metastasis. The trial continues to the final overall survival in patients without liver metastasis. As far as the efficacy, STELLAR-303 met its primary endpoint of overall survival in the intention to treat population. We have shown significant survival advantage with the combination as opposed to regorafenib with a stratified hazard ratio of 0.80, which translates into a 20% reduction in the risk of death in patients receiving the combination as opposed to patients receiving regorafenib. We have, with a p-value of 0.0045, the patients receiving the combination have a median overall survival of 10.9 months, as opposed to 9.4 months with regorafenib. We have seen an early separation of the Kaplan-Meier curves that remain consistently separated, favoring the combination thereafter. The 24 months overall survival estimates were 20% with the combination as opposed to 10% with regorafenib. As far as the interim overall survival analysis in the patients without liver metastasis, we have shown a stratified hazard ratio of 0.79, favoring the combination with a median overall survival of 15.9 months for the combination as opposed to 12.8 months with regorafenib. As far as the running, a forest plot looking at subgroup analysis of key subgroups, we have seen consistent relative benefit favoring the combination in all of those key subgroups. So the benefit seen regardless of presence or absence of liver metastasis, regardless of presence or absence of RAS mutations. And also a key point to highlight is prior exposure to VEGF-targeted therapy, which represented around 80% of the population of the study, did not diminish the benefit of the combination of atezolizumab plus zanzalintinib. So as far as the safety profile for the combination, most of the treatment-related adverse events seen were grade 1 to 3, and mostly are hypertension, diarrhea, nausea, fatigue, and loss of appetite. Of note, the grade 3 and all grade PPE or hand-foot syndrome were much lower with the combination as opposed to regorafenib, and that's despite longer median duration on treatment with the combination as opposed to regorafenib. And then another point to highlight is that we have not seen any new safety signals. The overall safety profile is consistent with the safety profile of similar combinations of VEGF multi-tyrosine kinase inhibitor in combination with immune checkpoint inhibitor that's available in other tumor types like renal cell carcinoma. So overall, I would like to highlight that metastatic colorectal cancer is considered a major global disease challenge with 150,000 cases expected to be newly diagnosed every year in the US alone, and a 5-year overall survival of around 15 to 16%. And so the success of STELLAR-303 study with the synergistic combination combining a novel targeted agent zanzalintinib with immune checkpoint inhibitor is potentially changing this trajectory. We are now looking at data analysis from the ongoing STELLAR-303 study, particularly the final overall survival in the subgroup of patients without liver metastasis. We're also looking at exploring the next generation of clinical trials that could be developed to capitalize on the results seen with the STELLAR-303, including potentially exploring the combination in earlier line setting in patients with metastatic colorectal cancer, and potentially exploring it in earlier stages of the disease as well, in the potentially neoadjuvant or adjuvant settings. And then possibly looking at novel immune modulators that could be added to the doublet to capitalize on the results. So overall, as a key take-home message, I would like to say that the STELLAR-303 study results are sending a clear message of progress and possibility. It opens a new era of immunotherapy-based chemotherapy-free combinations in patients with colorectal cancer that are not MSI high and not mismatch repair deficient.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this podcast, please leave a review and subscribe on your favorite podcast app, including Apple, Podbean, and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology and join in the conversation, and visit VJOncology.com for the latest updates in the field.